Hello everyone and welcome. If you are gearing up for the dermatology board exam, you know there are certain topics you just cannot afford to get wrong. And believe me, Paracoccidioidomycosis, or PCM, is right at the top of that list. So let's dive in and make sure you're ready to absolutely master it. Now, why is this so important? Get this. In Brazil, PCM is the 8th leading cause of death from chronic infectious diseases. We're not talking about just some obscure fungus here. This is a major public health issue, and that is exactly why the board exam takes it so incredibly seriously.
So here's how we're going to break it all down. We'll start big with the fundamentals of PCM, cover the fungus itself and how it presents. Then we'll get to the part I know you're waiting for, how to crush this on the exam. We're going to analyze past questions and even try to predict what's coming next.
First up, why do we call this the most important mycosis? Let's get right into why understanding PCM is non-negotiable for any dermatologist in Brazil. Okay, so by the book, PCM is the main systemic mycosis in Brazil caused by these dimorphic fungi. But this is way more than just a textbook definition. Its huge social and economic impact means that being able to spot it is a core skill for anyone practicing in the region.
All right, next section. Let's talk about the fungus and how it gets around. You got to know the enemy and its game plan, right?
We're dealing with two main culprits here. First, you've got Paracoccidioides brasiliensis. Now, this isn't just one thing. It's a whole complex of species you'll mostly see in the southeast and south of Brazil. Then there's Paracoccidioides lutzi, a separate species that really holds down the fort in the center-west and the Amazon. Remember that geography, it can be your very first clue in a test question.
So, how does the infection happen? The cycle is pretty straightforward, but you need to know it cold. The fungus hangs out in the soil as a mold. Then, say during farming, tiny spores get kicked up into the air and are inhaled. Once they're inside the nice warm lungs, they switch gears, transforming into their pathogenic yeast form. And that's when the trouble really begins.
Now, if you picture a classic PCM patient, it's a male rural worker. The male-to-female ratio can be as high as 10-to-1. And the reason is fascinating. It's hormonal. The fungus actually has estrogen receptors, and estrogen stops it from transforming into that nasty yeast form. This protective effect is a high-yield fact the board just loves to test. Clinically speaking, PCM is a disease with two totally different personalities, and you absolutely positively have to be able to tell the acute form from the chronic one. I mean, just look at the contrast. On one side, you have the acute, or juvenile form. This hits young people, moves fast, and targets the lymph nodes, liver, and spleen. On the other side, you have the chronic adult form. This is a much slower burn in adults over 30, and it classically involves the lungs and, this is key for us, the skin and mucous membranes. Even the immunology is different, a weak Th1 response in the acute form versus a Th2 dominant one in the chronic. And when we talk about mucocutaneous involvement, the mouth is ground zero. The one sign you have to burn into your brain is this, stomata moriforme, or mulberry-like stomatitis. It's this classic granular, reddish surface with tiny little hemorrhagic dots. This is often the very thing that brings a patient with the chronic form into the clinic.
And the numbers totally back this up. When you look at where these oral lesions pop up, the lips are number 1, followed by the oropharynx, and then the hard palate. So, what's the big takeaway? A super thorough oral exam is non-negotiable if you even suspect PCM.
Now on the skin, the lesions can look like a lot of different things. They're polymorphic. They can be papular, look like acne, or be ulcerated and crusted. They love to show up on the face, especially around the mouth and nose, and they often come from the fungus spreading from those mucosal sites or lymph nodes we talked about. Okay, we've laid a solid clinical foundation. Now, let's switch gears and apply this directly to the TED exam. How does the board take all this knowledge and turn it into a tricky multiple-choice question?
Let's get our hands dirty with a real one. Question 70 from the 2022 TED exam. It's asking for the correct statement about PCM's clinical signs and differential diagnoses. We're going to take this apart piece by piece.
All right, option A. It claims oral lesions are frequent in the acute juvenile form, but rare in the chronic adult form. No way. We know this is the complete opposite of the truth. Those dramatic oral lesions, that mulberry stomatitis, that is the calling card of the chronic adult form, so A is definitely out.
Let's look at option B. It talks about bone and joint involvement, saying it's common in the chronic form. Nope.
Wrong again. While bone involvement can happen, it's pretty uncommon. And when it does, it's much more associated with that fast-spreading acute juvenile form. The board is checking if you know the typical script for each form.
Okay, now option C brings up differential diagnosis, suggesting leprosy and chromoblastomycosis. This is a classic distractor. For those ulcerative oral lesions, the key things you need to think about are squamous cell carcinoma, mucosa leishmaniasis, and tuberculosis. Chromoblastomycosis, that usually shows up as warty plaques on the legs and arms, making it a really poor differential for something in the mouth.
See? When we break down that one question, a pattern starts to emerge. The board isn't just asking random trivia. They're hitting the same high-yield concepts over and over again.
So what do you need to laser focus on? First, oral signs. No mulberry stomatitis in your sleep. Second, those key differential diagnoses we just went over. Third, be able to instantly tell the difference between the acute and chronic forms. And finally, that classic patient profile. The male farmer, probably a smoker, from an endemic area. I promise you, these are the pillars of almost every PCM question you'll see.
Now that we know the patterns, we can do more than just analyze the past. We can actually start to predict future questions and map out a solid strategy for exam day.
So what could they throw at you next? Well, they might give you a case of the less common juvenile form and ask you to tell it apart from lymphoma or TB. Or maybe they'll test you on the newer species, P. lutzii, and its specific geographic home. You've got to be ready.
Here is a super simple 4-step framework to use the second you see a PCM question. 1. Analyze the patient profile, age, sex, job. 2. Hunt for those mucocutaneous clues, especially in the mouth. 3. Decide if you're looking at the acute/juvenile or chronic/adult form. And 4. Use that info to confidently knock out the wrong differential diagnoses.
In the end, mastering PCM isn't just about memorizing a list of facts. It's really about understanding a core pillar of Brazilian dermatology, seeing how the epidemiology, the science, and the clinical signs all connect to tell a story. Walk into that exam with confidence. You've got this. Good luck.